up to 24 hours. There can be a mechanical thrombectomy, endovascular therapy can be given or not. And in the light of recent article, Dr. Manisha is going to present, and Dr. Sunil and me are going to chair, and Dr. Prasad will join if possible for expert comments. And after the end of the presentation, we'll throw it open for all the participants to have their questions. Sunil, I hand over to you for further conduct.
Thank you, Dr. Goti. So this is, I think we are having the seventh or eighth journal club of the stroke subsection of Indian Academy of Neurology. We have it on to just remind for anyone who has joining first. We have it in the first week of the month, either on the first Monday or Friday. We have been having it on Fridays for the last 2-3 weeks because there was such a some of us expressed that interest to have it on Friday. So we'll just experiment and see which is more convenient.
Monday is a busy OPD day for all. That's the reason we have to.
That's right. Yeah. So Dr. Goti has already introduced today's team, which is from NIMANS. Dr. Kulkarni is leading the stroke team, and Dr. Manisha is going to be our presenter today. A very interesting topic. After a large number of small and at least a couple of big studies, trials on basal artery occlusion and mechanical thrombectomy, which have been rather inconclusive, though we have anecdotal spectacular results also reported. The challenging problem of basal artery occlusion remained unsolved because all the major trials, even the earlier thrombolytic trials, they were all confined to the MCA territory infarcts. But we all know that in practice, basal artery occlusion is an extremely important problem as well. It's another valiant attempt by the team from Beijing University to study the trial of thrombectomy. We had some information that within 6 or 8 hours, there were various intra-arterial thrombolysis available. But then here it is from 6 to 24 hours, basilar artery mechanical thrombectomy is the intervention which is being specifically tried. And let us listen to Manisha, and I now hand over to Dr. Kulkarni to start the proceedings. Thank you.
Sir, good evening. At the outset, I thank behalf of our NIMANS stroke team, myself, Dr. Deepak, Dr. Preetham, Dr. Shubhashri, and Dr. Sri Jitesh, and all our residents for this opportunity to present. As all of us know, that there is a tremendous interest and increase in management of the large artery strokes, both in window and beyond the window in the anterior circulation. And we have very good results. And the late windows with good selection have much better outcome compared to the CT. Now we have another large vessel, the basilar artery, which has a very low incident but has a devastating effects on the patient. And whatever the data we had from the registries, retrospective studies, and a few small RCTs, it was conflicting. Now we have a very interesting and important studies coming from China, and which have come out with positive results. And within 6 hours, 8 hours, and 12 hours. Now we have come to a situation where we have a EVT trial in basilar artery, which is very rare, and beyond 6 hours. And Manisha will be presenting this. She is working as a post-DM, postdoctoral fellow in our stroke unit. And I hand over Manisha to present her journey. Thank you.
Thank you, sir. And thank you, everyone. Good evening to everyone. I'm really happy to present in the iron stroke subsection. So today I will be presenting a very interesting article which has changed our perspective of posterior circulation strokes. I hope my slides are visible.
Yes, ma'am.
Yes.
Okay, thank you. So my moderator will be Girish sir. So this article is trial of thrombectomy 6 to 24 hours after stroke due to basilar artery occlusion, also known as the Bausch trial. The primary author of this study is Dr. Jovin, and Dr. G from Beijing is the corresponding author. This was published in NEGM in October 2022. So coming to the introduction, basilar artery occlusion is an infrequent form of acute stroke which invariably leads to death or long-term disability if not recanalized. Despite accounting for only 1% of all ischemic stroke cases, it tends to cause the most desolate strokes. There are plenty of randomized trials for patients with acute stroke due to large artery occlusion and anterior circulation, which have shown benefit of EVT. The evidence of mechanical thrombectomy in acute basilar artery occlusion has until now remained inconclusive. Current guidelines lack specific EVT recommendations for posterior circulation. So what our recent guidelines say? So as per the AHA guideline 2019, although the benefits are uncertain with the use of mechanical thrombectomy with stent retrieval, it may be reasonable for carefully selecting the patient within 6 hours for basilar artery occlusion cases. However, the class of recommendation is 2B and the level of evidence is C with limited data. Also, the European Stroke Organization 2021 guidelines also suggest that there is a consensus among the panel that in analogy to anterior large vessel occlusion and with regard to grim natural course of basilar artery occlusion, the therapeutic approach with IVT plus MT should be strongly considered. So, what does the previous study say? There were many retrospective studies for basilar artery occlusions in the past 2 decades. Here is a summary of 18 retrospective studies which were there. So here we can see that the NHS score ranged from around, it was more than 15. IVT was used in such cases in around 20 to 30% of the cases. However, coming to the favorable outcome, we see that favorable outcome range from 27.1% of the cases to around 46.9% of the cases. And from the pool data, we see that the favorable outcome, mean favorable outcome is around 36.4% only. The symptomatic ICH also varied in these studies. And from the pool data, the symptomatic ICH percentage was 4.6. And the mortality is around 30%. So most of these studies were done in last 2 decades. The median NHS, as I told, ranged from 14 to 31. The rate of receiving IVT varied from 14 to 45.1. Median or mean onset to treatment time range from 3.8 to 10.4 hours. And stent retrievers or direct aspirator devices were most commonly used in these studies. The rate of favorable outcome, as I have suggested, was around mean was 36.4%. And the multivariate logistic analysis revealed that time to recanalization and early neurological improvement, good collateral circulation, and distal basilar artery occlusion were independent factors for favorable outcome after EVT. There were prospective registries also, which were there for basilar artery occlusion. So as per a prospective study registry by Singer et al., which included consecutive 148 cases, we can see the median NHS score was 20. IVT was used in around 59% of the cases. Favorable outcome was seen in 34% of the cases. Symptomatic ICH as a safety parameter was seen in 5.4% of the cases, and mortality remained around 35, just like the previous retrospective studies. And it also showed that initial stroke severity and the collateral status predicted good clinical outcome. In another prospective, which et al., the EVT and medical treatment group, and as we can see here, the median NHS remained very high, like around 27 or 26.5. And as we can see here, the favorable outcome in the EVT group was achieved in 27.4% of the cases in comparison to the medical treatment group, where it was achieved in 7.1% of the cases. The p-value remains significant for this. Also, the symptomatic ICH, however, was more in the EVT group of around 7.1%. And we can see that there was a significant mortality benefit also, seeing that EVT group had only 46.2% of the cases who had mortality in comparison to the medical treatment group, where 71.4% of the cases had mortality. So it was also suggested by this non-randomized registry that the number needed to treat was 4.4 for one additional patient to be able to walk unassisted. Then came the era of RCTs. So one of the first RCTs, which is the basic trial, it was a Dutch trial and it recruited around 300 patients. The duration within which the patient was recruited from the time of onset of symptoms was 6 hours. They were randomized in 1:1 ratio, and the outcome parameters which were assessed were favorable outcome of MRS score between 0 to 3 and the mortality at the 90 days. So finally, the results resulted in approximately 80% of the patients in each group received IVT, but the result did not show any significant favorable outcome with EVT per se. So, and also we saw that there was symptomatic ICH, which was more in the EVT group in comparison to the medical treatment alone group. However, this trial had many other problems, like there was slow recruitment, which questions the presence of bias in the enrolled population. Also, there was high rates of treatment of eligible patients outside the trial. Around 29.2% of the patients were treated outside the trials, of which high percent of patients went on to receive EVT. Around 79% went on to receive EVT. Also, there were amendments to the methodology to facilitate recruitment. This was seen when they have also included patients with NIHs less than 10, which could lead to an undervaluing of the effect of EVT. Another one of the big studies was the BEST trial. This was conducted in China. So this was a multi-center randomized open label blinded outcome trial in which patients here were recruited within 8 hours of onset of symptoms, and they were recruited in randomized as per 1:1 ratio. The same primary outcome parameters and safety outcome parameters were assessed. However, they saw that there was no evidence of difference in favorable outcome of patients receiving EVT when compared to best medical therapy. But these results were confounded. Why? Because there was a high crossover rate of around 13%. And the trial was also terminated early with only 131 patients being recruited. Noticeably, also, patients in the intervention group had higher NHS of 32 in comparison to the control group, which had median NHS of 26. But if we see in detail, leaving the intention to treat part, we see the per protocol analysis and the as treated analysis. Here we see that the adjusted odds ratio is 2.9 in per protocol group and 3.0 in as treated group, which favors more towards mechanical thrombectomy. Then comes one of the most successful trials, which is attention trial. So this is a sister trial with Bausch trial. So this was conducted again in China. It recruited around 340 patients, and they were recruited within 12 hours of onset of symptom, randomized within 2:1 ratio. And same parameters of primary and safety outcomes were assessed. They saw that the percentage of patients with good outcome had good functional outcome was twice as high in the thrombectomy group in comparison to the control group. And approximately only 1/3 of these patients had received IVT. Also, symptomatic ICH, which was observed from 24 to 72 hours, occurred only in 5% of the cases, which is almost same as per the percentage in the anterior circulation large vessel strokes. Mortality was very low in these cases with the thrombectomy in the thrombectomy group. This is the meta-analysis of the 4 major basilar artery occlusion trials. So here we can see that the favorable outcome was seen more towards the mechanical thrombectomy. It is more favoring mechanical thrombectomy, and even the p-value is 0.03, which is suggesting that patients with favorable outcome are more happening with the intervention of mechanical thrombectomy. As we can see, mortality data also, even though symptomatic ICH is more in cases of mechanical thrombectomy group, but mortality is however less, and it is favoring that a p-value of 0.004 is being achieved, hence showing that the mortality is of course very less in the mechanical thrombectomy group. Then what the risk of symptomatic ICH is of course more in the mechanical thrombectomy group, with the p-value of being 0.001. So what was the need for this study, the Bouch study? It has seen the effect and safety of endovascular thrombectomy in basilar artery occlusion on a background of mixed evidence from the best basics and attention trial. It has been postulated that the anatomical and pathophysiological characteristics of brainstem and cerebellum, which are supplied by branches of basilar artery, make them more resistant to ischemia than structures supplied by the anterior cerebral circulation. What were the harms in doing this study? Symptomatic ICH, neurological deterioration, and mortality. So, of course, the benefit we have to look into in comparison to the harm. So, we have to outweigh. So, what is the objective of this study? The objective of the study is to evaluate the hypothesis that mechanical thrombectomy is superior to medical management alone in achieving favorable outcome defined by MRS of 0 to 3 at 90 days in subjects presenting with an acute ischemic stroke caused by occlusion of basilar artery, who can be randomized within 6 to 24 hours after the symptom onset or last known well status. So, coming to the research question, patients included in this study is presenting within 6 to 24 hours of the symptom onset or last known well status, and who were more than 18 years of age. The intervention included mechanical thrombectomy with or without angioplasty and subsequent stenting. Then the comparator group was the best medical therapy. The outcomes which were assessed, the primary outcome was MRS of 0 to 3 at 90 days. Primary safety outcome was mortality at 90 days and risk of symptomatic ICH. And various secondary outcomes were assessed, out of which one was good MRS score of 0 to 2. So coming to the study design, this was an investigator-initiated multi-center open-label randomized control trial. The outcome was blinded for evaluation. It was conducted over a 5-year period in China from August 2016 to June 2021. Patients were randomly assigned in a 1:1 ratio. It was funded by unrestricted grant from Chinese National Ministry of Science and Technology, which was not involved in the design or conduct of the trial. There was no industrial involvement. The trial sites were certified stroke centers in China, at which more than 500 patients with acute stroke had been treated, and more than 30 stroke thrombectomy procedures had been performed annually. Also, the neurointerventionist on the staff had performed minimum of at least 10 thrombectomies with solitaire device. What was the intervention? Intervention was thrombectomy, and rescue perfusion therapy with other devices or pharmacological agents was not permitted except for balloon angioplasty or stenting of the vertebral artery or basilar artery. Medical management group. So as the label for, this was the label for control arm, which means no intra-arterial intervention with drugs or devices. Furthermore, after randomization, a subject could not be placed on intravenous thrombolysis. So there were multiple scientific committees. First was the steering committee.
Manisha?
Yes, sir.
We could just Anything about sample size?
Yes, sir, I will be discussing, sir.
All right, okay.
So coming to the steering committee, so it helped in designing and supervision of the study. The eligibility of the centers and the physicians were also taken care by the steering committee. And it also helped in maintenance of complete, legible, well-organized, and easily retrievable data. There was also a data safety monitoring board, which was very important. It helped in reviewing regular basis of accumulating data. It helped in evaluating the interim analysis, which will help in making recommendations to the EC committee that regarding stopping or extending the trial, and it will help in reviewing the occurrence of adverse events and make recommendations to the EC regarding safety of the study. There was a clinical event committee which educated the cause of death and serious adverse events. It establishes explicit rules outlining the minimum amount of data required and the algorithm to be followed in order to classify a clinical event. There were also core labs. 2 central imaging core labs were there, which independently reviewed the CT, MRI, or DSA images. So coming to the hypothesis, the null hypothesis for the study is mechanical thrombectomy has similar outcome as medically managed patients in achieving favorable outcome defined as MRS 0 to 3 at 90 days in subjects presenting with ischemic strokes of basilar artery who can be randomized within 6 to 24 hours from symptom onset or last known well status. Alternative hypothesis is mechanical thrombectomy superior to medical management alone. So coming to sample size calculation, for the treatment group, the proportion of death or its equivalent state, which was MRS 5 to 6 at 90 days, was estimated to be 40% based on previous study who had met the entry criteria for Bausch trial. For the control groups, the proportion of MRS patients with MRS 5 to 6 at 90 days was estimated to be 60% based on the literature published at the time when the initial protocol was conceived. So this estimate yields an expected difference in proportion of 20%. Type 1 error of 0.05% was taken and type 2 error of 0.1% was taken. With this, the sample calculated was 254 using the PAS13 software. Adopting an O'Brien-Fleming stopping boundary using the Land-Limit spending function with one interim analysis or a final analysis, the maximum sample size of the subject becomes 286. Considering an inflation factor to safeguard against the loss to follow-up, which was considered 10% in this study, the total sample size rose to 318 subjects. And when the interim analysis will be planned, for checking the overwhelming efficacy, two-thirds of the patients will be taken into consideration, the number amounting to 212 patients in this case. So, but there was a change in primary outcome analysis while the study was being conducted.
Can I interrupt a little bit? Just because I may have
Yes,
to.
sir. Yes, Dr. Prasad. Manisha, please.
Yeah.
The
only small point I want to make is
yes,
that once a study is completed, right, it is whether sample size was enough or not is already evident from the analysis with, of course, p-value and 95% confidence interval. So, because prior to the study, sample size calculation is done on the basis of certain assumptions. And those assumptions are that event rate will be this in control group, event rate will be this. And more often than not, actual event rates differ from the event rate which authors hypothesize. So when we are planning a study, sample size calculation is absolutely necessary because that will determine your budget, that will determine your strategy of recruitment and so on. But once the study is completed, then there is no point looking at sample size because this is already evident from the 95% confidence interval. I'm saying this because residents may not appreciate this, that if sample size was not enough, you will find wide confidence interval overlapping the side of benefit as well as harm. Means too wide to be meaningful. If sample size was enough, then also confidence interval will be narrow enough to be meaningful. So if you know which confidence interval is meaningful and not meaningful, you can see whether sample size is enough or not when you look at the results. So this is just a point to keep in mind. Critical appraisal does not require sample size calculation method. This is enough to know that study had done sample size calculation, means it was well planned. But how did they do it? What was the event rate? What was the adjustment for losses to follow up, interim analysis? All of this will be summarized in 95% confidence interval. Please go ahead. Sorry to interrupt you, but I will have to perhaps after a few minutes, my boarding will start. That is why I thought I should make this comment.
Thank you, sir. Thank you very much.
Thank you, sir.
Thank you very much.
Thank you, Dr.
Okay.
Thank you.
So there was a change in primary outcome analysis while the study was being conducted. Initial primary outcome analysis was MRS of 0 to 4 patients who were achieving this MRS at 90 days. However, when the study was being conducted, the MRS primary outcome was changed such that the MRS between 0 to 3 at 90 days was being considered as the primary outcome. So why did they not change the sample size is the question. So based on the per protocol analysis of the BEST trial and the Chinese registry data, they saw that difference in rate in favorable outcome remained 20%, which was also there in the original protocol. And also to deviate as little as possible from the initial statistical plan, the assumptions leading to the initial sample size calculation of total sample size of 318 with interim analysis of 212 patients were left unchanged. So here we can see that the BEST trials per protocol analysis showed that the difference was around 18.9% and as treated analysis was 22.6%. And also for the Chinese registry, the difference between the EVT and the medical treatment group was 22.7%. So there was an interim analysis planned for the study. It was planned when first 2/3 of the patients would have been enrolled and would have completed minimum of 90 days follow-up. The computation of alpha for the interim and final analysis was done by alpha spending approach using the PAS13 software. O'Brien-Fleming stopping boundaries was used. The nominal alpha levels using this was 0.012 for the interim analysis and 0.46 for the final analysis. So as we will go through the slides, we will come to know that the study achieved a significant p-value at the interim. Hence, it was stopped at the interim analysis itself. At the interim analysis, when the stopping boundaries were crossed, the study was stopped for either overwhelming response for whichever treatment is superior. However, if the conditional power fell down below 20%, then the study would have to be stopped for futility. So in coming to the inclusion criteria, this included patients with posterior circulation acute ischemic stroke within 6 to 24 hours from symptom onset to last known well status, where the patient is ineligible for IVT or the treatment is contraindicated, or where the patient has already received IVT but without successful recanalization. Initially, they did not include the isolated vertigo as the symptom in the initial version of the protocol. However, they introduced that isolated vertigo will not be considered as the onset of symptom in the subsequent versions. The occlusion will have to be TIMI 0 to 1 for the basilar artery. Then later they introduce this addendum where the occlusion of intracranial V4 segment of both vertebral artery, which will be like a functional occlusion of basilar artery, was considered as an inclusion criteria. This will be evident by CTA, MRA or DSA. Ages more than 18 and up to 80 were included in the study. the baseline NHS score obtained prior to randomization must be equal to or higher than 10 points. However, because there was slow recruitment initially in the study, they changed the NHS score as well to include patients who had NHS score of 6, no signal or equal to 1. Patients treatable with patients should be presenting within 24 hours of the should have started, which is the groin puncture, within the 24th hour. And the anticipated life expectancy of at least 1 year should have been there, and informed consent should have been obtained from patient or acceptable patient surrogate. So one of the major exclusion criteria were posterior circulation acute patients who were presenting with PC aspects of less than 6, or Pons midbrain index of more than equal to 3. So what is this Pons midbrain index? Basically, we have to divide Pons in midbrain into 2 equal halves. And if the infarct is less than 50%, causing left is there in less than 50% of the Pons or either midbrain, it will be counted as 1 point. If it is more than 50%, it will be counted as 2 points. This will be seen either in CT angio source images or MR diffusion weighted images. This imaging modality was also changed during the subsequent versions of the protocol. They used non-contrast CT as the new imaging modality, along with the previous imaging modalities being there. CT or MRI evidence of hemorrhage should be absent, otherwise the patients were excluded, except for patients with microbleeds, which were allowed. So here, coming to PC aspect, so 1 score will be given either to either hemispheres of the cerebellum, 2 for Pons, 2 for midbrain, 1 for either thalami, and 1 for either of the PCA territory. So other salient exclusion criteria was if patient was having known hemorrhagic diastasis, or patient had some coagulation factor deficiency, or patient was on oral anticoagulation with INR of 3 or more than 3. The platelet count, if it is low, if patient blood glucose was below 50 or more than 400, if patient had sustained hypertension, or if patient was sedated or intubated, leading to the evaluators not able to check the baseline NHS if there was a seizure at onset, if patient had received IVT beyond 4.5 hours from the onset of symptoms, if patient had presented acute stroke within 48 hours of a percutaneous cardiac or cerebrovascular intervention or major surgery, if the patient had renal insufficiency, and woman of childbearing potential who was either pregnant or lactating. So other neuroimaging criteria for exclusions were if patient had a cerebral infarct which was either causing mass effect or compression of fourth ventricle, there was complete unilateral bilateral thalamic infarction, and evidence of vertebral occlusion or high-grade stenosis or arterial dissection in the intracranial or extracranial segment that could not be treated or will prevent the access to the intracranial clot, or excessive tortuosity of the cervical vessels precluding device delivery and deployment. Subjects with occlusion in both anterior and posterior circulation were also excluded. So this randomization, patients were randomized in 1:1 ratio using a central web-based computer-generated schedule. Imbalances of randomization were minimized by stratifying according to the following category of baseline factors, which were age of more than or less than 70 years, baseline NHS of between 6 to 20 and more than 21, therapeutic window who were presenting between 6 to 12 hours and more than 12 hours up to 24 hours. The primary endpoint of functional independence in 90 days was assessed by a local evaluator, which was blinded to the treatment, and a central independent MRS certified evaluator. In case of disagreement, of course, the central blinded evaluator's opinion was taken into account. Secondary endpoint included hemorrhages, which were determined by CT or MRI core lab, which is also blinded to the treatment. Data prepared for presentation to the DSMB committee was presented in either A or B format, and 2 statisticians, one partially unblinded for regular reporting and another one which was completely blinded throughout the study. The second one served on the executive committee. So, coming to the procedure, after the patient satisfied the inclusion criteria, patient was randomized either into the thrombectomy group or the best medical therapy group. Thrombectomy along with best medical therapy was, whosoever was randomized to this group, they underwent minimum of 6 passes to recanalize the vessel plus minus angioplasty. So for any of these patients, the baseline clinical parameters were seen, like patient's NIHS, and radiological parameters were also seen, whether like the patient had a basilar artery occlusion, then vertebral artery occlusion. All these were assessed at baseline. Once the patient had undergone thrombectomy, or either she has not undergone thrombectomy, on day 1 patient were assessed clinically as well as radiologically. Clinically, patients NIHS and MRS, all these were taken into account, and radiological parameter in the form of whether recanalization was achieved using CT angio, MR angio, or in some cases DSA as well. Then at day 5 or day of discharge, whichever came earlier, the clinical parameters in the form of NIHS and MRS was assessed. At day 90, again, clinical parameters was assessed in the form of NIHS, MRS, and also other disability scores, which I'll be covering. So this is how patients' sheet was being maintained. The baselines parameters, including consent, randomization, the clinical parameters, then the radiological parameters were checked. During the procedure, patient's angiogram details were also assessed, and if patient developed any serious adverse events, that was also taken into account. Then at 24 hours, patient's NIHS as well as recanalization or any serious adverse event parameters were assessed. Then at the time of discharge or at day 5, MRS or NIHS was assessed, and also if any of the patient developed any serious adverse events. Then again at 90 days, patient's NIHS and MRS was assessed, and patient was also assessed with other measures of disability like Barthel index and EQ5D measures, and also if patient developed any serious adverse events. Patients were also assessed later at 3, 6, and 12 months, but this was not covered in this particular journal. So coming to the outcome parameters, which were assessed, the primary endpoint was patients achieving meaningful outcome better than death or equivalent, which was MRS less than or equal to 3 at 90 days, as evaluated by independent certified central assessors who are blinded to the treatment. This was a change from the original primary outcome, which was there in version 1 of MRS being less than equal to 4. The safety endpoints, which primary safety endpoints were mortality at 90 days and clinically significant ICH at 24 hours, which was seen with the help of Sitzmo's definition, which is parenchymal hemorrhage type 2, which is causing patient NIHS to rise by minimum of 4 points. And the other outcome parameters which were assessed were, so secondary endpoints were dramatic early favorable response as determined by an NIHS of 0 to 2, or NIHS has improved drastically by more than 8 points at 24 hours from randomization or before discharge. If and vessel recanalization, which was assessed at 24 hours in both treatment group as well as the control group, and it would have been assessed by arterial occlusive lesion grades. The vessel recanalization post-procedure in thrombectomy group was assessed by MTK grades. Then dichomatization between MRS scores of 0 to 2 versus 3 to 6 at 90 days was also assessed. Shift analysis was done at 90 days, Barthel index at 90 days, NIHS at 90 days, and also patient quality of life analysis was done with EQ5D 3L measures. Secondary safety analysis was symptomatic ICH by ICAS-2 definition, which is any hemorrhage, which is causing increase in NHS of more than 4 points, or any other serious adverse events were considered as safety outcome parameters. So, all the statistical analysis were based primarily on the intention to treat principle. Analysis were also performed in the per protocol population as well as treated population. Categorical data were denoted with number and percentages of each patient in category, and two-sided 95% Copperfield-Pearson confidence interval for response rate was determined using the exact binomial method. Continuous data was denoted with in this number of non-missing observation and number of missing observations were taken into account. Mean, standard deviation, median, the interquartile interval, and the range between minimum to maximum were assessed. All data processing and summarization and analysis was performed using SAS version more than 9.4. Primary analysis was conducted by logistic regression in order to control for covariates. Statistical comparison of efficacy outcome according to treatment group were adjusted for age, baseline NHS, time from stroke onset, and are presented in adjusted rate ratio with 95% confidence interval. There was no plan for adjustment for widths of confidence interval for secondary outcome for a multiple comparison. If 90-day MRS score were missing, but the patient was known to have survived 90 days, then the last known MRS was imputed and a MRS score of 6 was assigned if case patient survival status was unknown or if patient was missing. In the adjusted ordinal analysis, which was carried out with MRS score 5 to 6 collapsed into one category, common odds ratio was used. A Kaplan-Meier analysis was done and the mortality rate in each arm at 90 days with accompanying 95% confidence interval was also presented. A descriptive analysis of study defined adverse event was presented in aggregate by event and rates, and 95% confidence interval was provided. So coming to the consort diagram, 537 patients were screened for eligibility. 319 were excluded. A majority of them were excluded. Why? Because 186 did not meet the either inclusion criteria or met the exclusion criteria. 133 declined to participate, and 101 patient underwent EVT outside the trial protocol. So only 218 patients underwent randomization. One patient, however, withdrew informed consent in the control group. So 110 patients were assigned to the thrombectomy group. In this, one patient crossed over to the control group. One was lost to follow-up at 90 days. Hence, in the intention to treat analysis, 110 patients were included. 102 were included in the per protocol analysis and 113 in the as treated analysis. In the control group, 107 patients were assigned. 4 crossed over, however, to the thrombectomy group. 2 were lost to follow-up at 90 days. 107 were included in the ITT analysis. 100 were included in the per protocol analysis. And 104 were included in the as treated analysis. As we can see here, the enrollment in this study initially was slow. However, after around mid of 2018, there was increase in rate of enrollment.
It was because they changed the enrollment criteria.
So the enrollment
They
criteria.
decided to take people with
Yes,
lesser
sir.
NIH stroke scales also.
Yes, NIH more less than when they started taking more than 6 as the criteria, then the enrollment little bit, the rate increased, sir, actually. Yes, sir. Coming to baseline characteristics, the missing primary outcome data were imputed for 3 patients. The primary analysis was used central evaluation, which included 31 video and 59 audio when available, and local evaluation in the remaining 47 cases. Median age of the patient was 65 years and 27% of the patients were women. Randomization occurred at a median of 663 minutes after symptom onset. Median NIH score was 20. Median PC aspect was 8. IVT was administered to 18% of patients overall. Out of this, 14% were 14% of the thrombectomy group patient had received IVT, and 21% of the control group had received IVT. Thrombectomy was performed in 106 of the 110 patients who had been assigned to the thrombectomy group. Rest of the patients, spontaneous recanalization was achieved with, not spontaneous, with IVT, or spontaneous recanalization was seen. General anesthesia was used in 72 patients who had been assigned to the thrombectomy group. Intracranial angioplasty or stenting after failed thrombectomy was performed in around 55% of the cases. So these are the baseline characteristics. Here we can see there was marginally increase in age in the thrombectomy group. That was like 64.2. And if we see, the majority of the patients were male. As per the medical history, the patients with atrial fibrillation and diabetes were slightly more in the thrombectomy group. Also, patients of hypertension were slightly more in the thrombectomy group. However, the MRS score of 0 before the stroke was lesser in the thrombectomy group and more in the control group. Then patients with NIHs of 6 to 20, that is the lower NIHs, was more in the thrombectomy group in comparison to the control group, and patients, those who had NIHs of more than 20, slightly higher percentage is there in the control group. Then patients, as I have told, PC aspects, median PC aspect has been 8 and median Pons midbrain index has been 1. And IVT percentages has been previously covered. Then patients with basilar, if we see the basilar artery occlusion slide, many of the patients presented with proximal basilar artery occlusions in both the groups, followed by mid-basilar artery occlusion. The least were the distal basilar artery occlusion. Then patients who were presenting within 6 to 12 hours were more in the control group as comparison to the thrombectomy group, and patients who were presenting more than 12 hours were more in the thrombectomy group. Then median duration from stroke onset to randomization was 664 minutes in the thrombectomy group and 662 in the control group. Then from stroke onset to revascularization, the median time was 790 minutes. And from groin puncture to revascularization, the median time was 85 minutes.
This baseline, okay, that's MRS scores.
So baseline MRS score, this they have this much only given the data that the percentage of patient with MRS of 0 was 77% in the thrombectomy group, and the at the baseline, and 83.
That is before stroke.
Yes, sir.
But at the time of presentation, in the two groups, the baseline MRS scores are not given, no?
No, sir. NIHS is given for that, sir, in this case.
No, and MRS is primary outcome. So it's important to have some idea about it would have been nice to know the baseline.
MRS outcome at the entry. Why do we require MRS?
It's very important now, because if somebody is having a larger MRS at the entry, naturally their final MRS will also be higher.
That is for the recurrent strokes. Huh?
No. See, suppose someone, obviously there will be the outcome with somebody with a 5 MRS and 2 MRS will be different. Whatever, irrespective of whatever intervention you give.
Okay.
So
Now, stroke severity
given NIH stroke scale, they were given the comparison, but the
MRS is actually the outcome scale. So we should look at the outcome, not at the entry point, I thought.
It's a disability scale, which is used for.
Okay. So, continue, please.
Continue.
So when the primary and secondary outcomes were analyzed in the intention to treat analysis, this was where the number of patients were 217. So this trial was stopped at the interim analysis itself. The reason being, around 46% of the patients in the thrombectomy group achieved the primary outcome, and 24% patients only achieved the primary outcome. The adjusted value for risk ratio was 1.81, and this was showing significant p-value. Since the significant p-value was achieved for the primary outcome, hence they stopped itself at the interim analysis. Then, as we see the secondary outcomes, a very good MRS score between 0 to 2 at 90 days was seen in 39% of the cases in thrombectomy group versus 14% in the control groups, adjusted value being 2.75. Then what was the initial primary outcome, which was 0 to 4, that was achieved in 55% of the cases in thrombectomy group and 43% in control group. Then there was a dramatic neurological improvement. That means NIH is improving by more than 8 points in around 25% of the cases in thrombectomy group and 10% in control group. The Barthel index scores between 95 to 100 was seen. That is a better Barthel index was seen in thrombectomy group. Of around 36% of the patient had shown this better Barthel index scores in comparison to 18% only in the control group. Then the basilar artery patency, which was evaluated with the help of repeat CT angio, MRA or DSA at 24 hours, of course, was more in the thrombectomy group. 92% of the patient had achieved this basilar artery patency in comparison to 19% only in the control group. The adjusted value for this is 4.53. Then the median EQ 5D3S measures were, of course, better in the thrombectomy group in comparison to the control group. And the reperfusion on DSA, which I'll be discussing, was achieved in 89% of the cases in thrombectomy group. So this
initially planned primary outcome just stops short of being significant. If you look at the confidence intervals, 0.95 to 1.54, but the redecided primary outcome shows a significant difference, isn't it? Right?
Yes, sir.
Yes, sir.
Then also this data was analyzed in the per protocol analysis. And again, we see that the adjusted value is 1.77 for the primary outcome. And also for the as treated analysis, the adjusted value was 1.68. So they have also done the ordinal shift analysis, where they had seen the MRS score at 90 days in the ITT population, and they found that the adjusted common odds ratio was 2.64, favoring more of thrombectomy. They have also done the shift analysis for the as treated population, and this also favored the thrombectomy group. Then they had done sensitivity analysis in which they had done the they have seen that the MRS being calculated by the central evaluator versus the local blinded investigators. So as previously seen, the adjusted risk ratio was 1.81 in for the primary outcome. And if they when they did this this primary outcome was analyzed by blinded local investigators, then the adjusted value is 1.88. So like near almost there was not much difference between the investigator associated evaluation. Then details of neuroimaging, which was available for baseline at follow-up. As we can see here, the most common modality which was used for imaging such patient was the CT angio source image versus NCCT, which was around 50.2% for baseline patients, and thereafter in 26.7% of the patient. Thereafter, it was the MRI diffusion only, which was available in 17.1% of the patient, and thereafter the NCCT, which was alone done as the imaging modality in around 15.2% of the patient. Same we can see here that follow-up was seen in DWI for 19.8% of the cases and 20.3 in patients underwent NCCT at 24 hours. So a recanalization post-thrombectomy, the data was available for only 101 patients because one patient crossed over to the control group and there was missing data for 8 patients. It was seen that majority of the patient achieved good recanalization of TICI score of 2B or 3. Around 89% of the patient had achieved this good outcome. Basilar artery patency at 24 hours as assessed by CT angio or MR angio was observed in 92% of the patient thrombectomy group versus only 19% in those in control group, which I previously highlighted. Then the primary and secondary safety outcome, as they have done the analysis by the ITT, intention to treat, here we see that the death within 90 days was, of course, very much lower in the thrombectomy group of around 31%, and in the control group it was 42. However, the adjusted value for this is 0.75. And then the symptomatic ICH, which is the another primary safety outcome. So as per the SITS-MOST criteria, when they analyze the symptomatic ICH, this was 6% in the thrombectomy group versus 1% in the control group, and the adjusted value was 5.18. However, this has not been sorry, it was not the adjusted value. They had not adjusted the symptomatic ICH with multiple other comparisons. Also, they had done the symptomatic ICH classification as per the ICAS-2 criteria as well, in which 9% of the patients in thrombectomy group had the symptomatic ICH versus 2% in the control group. These safety analysis data, however, were not calculated as per protocol analysis, and symptomatic ICH values were unadjusted. Then other serious adverse events which were seen as per the ITT analysis, here we see that malignant brain edema was more in the thrombectomy group. Around 12.7% of the patients had this, and GI hemorrhage was also more in the thrombectomy group, around 13.6% of the cases. Then they have done the forest plot for the subgroup analysis in the ITT population. So here, as we can see here, they have done the subgroup analysis for age, sex, NIHS, and then the symptom for the randomization window, the baseline PC aspects, and the location of basilar artery occlusion. All these favor more towards the thrombectomy. Same was also seen when the subgroup analysis was done in the as treated population, that the thrombectomy was being favored more. So coming to the discussion.
No, I think in that slide, subgroup,
Yes, sir.
what you have to say is whether how the individual subgroups differed in response. That's what you have to discuss in a subgroup analysis.
Okay, sir. So in
So
both,
you can see the, for example, if you see the the age group,
yes, sir.
less than 70, it's significant. More than 70, it's actually the confidence intervals are crossing the midline.
Yes, sir.
Crossing 1. Similarly, if you look at the NIH stroke scale, when it is more than 20, it's not significant. The confidence intervals are crossing the midline there. See, that is what you should do. That's what we
Yes,
are
sir.
doing the subgroup analysis. Of course, it has got its own limitations in interpretation, but what we are primarily looking for in a subgroup analysis is that
Yes.
one, whether not overall it favors which one is favoring, and how does that favoring differ between the subgroups. Okay.
Yes, sir. So the primary endpoint analysis showed favorable outcome in the thrombectomy group in comparison to the control group. Thrombectomy was associated with procedural complications also. This was seen in around 12% of the cases, and cerebral hemorrhage that may have been the result of reperfusion were higher in the thrombectomy group in comparison to the control group. The number needed to treat for
No,
this.
but is it significant?
No, sir.
Significant
They have not calculated the p-value per se, but the this adjusted value and the confidence interval is very wide. The adjusted value is 5.
Yeah. So we cannot say that statistically significantly higher hemorrhages occurred in the thrombectomy group.
Just
It's crossing midline also and wide confidence interval.
Yeah.
0.64 to 42.
only because the number of patients suffering from this particular outcome was very less.
Very low, very low.
Mm.
That's true.
So number needed to treat was 4.5, and number needed to harm calculated was 8.9. The overall rates of symptomatic ICH were low in both groups and are similar to that seen in anterior circulation. Mortality at 90 days was similar in two groups. The results differ from those of some other trials like the best and basics. However, it is similar to the attention trial. There were large number of patients who were screened outside the trial protocols in the basics that I have previously told and best, leading to a degree of bias in the study population. And there were also high crossover rates in the best trial, which may have diluted the size of the treatment effect in these trials. However, attention and Bausch trials had rapid recruitment, but as we see, Bausch had little slow recruitment initially with minimal crossover rates. Role of thrombolysis and optimal time windows in order to achieve reperfusions were, however, unanswered in this trial. Use of tenecteplase in this trial was this particular question was not answered since none of the patients were thrombolized with tenecteplase. There is still uncertainty regarding the benefit of thrombectomy as compared to the medical care in patients who presents with NIH score of less than 10, as majority of the patients in this study had NIH score of more than equal to 10. Regarding the use of imaging for selection of patients with stroke due to basilar artery occlusion, who will undergo thrombectomy, suggestion could not be made as the patients with brainstem involvement and lower PC aspects were not included. Coming to the strengths of the study and implication, the strength is that it included a large homogeneous population. There was uniform intervention in this particular trial, and same management was carried out in the experimental group following the intervention and in the control group. It was a government-funded study, and there was lesser crossover rates in this study. There was minimal loss to follow-up data. Hence, this study lays the stage of similar studies with multiple other factors being analyzed in a huge population, which is homogeneous. For example, in India, such a stage is being laid out by this study. So, what are the limitations of this study? There were protocol changes which were made during the trial, notably to the primary outcome on the basis of the data from other trials which were unavailable at the time of protocol design. Revised outcome of MRS 0 to 3 as representing good functional status was considered to be meaningful to the patient. It is the primary outcome in the other randomized trials as well. This change was implemented by the steering committee while its members were unaware of the trial results. This study is not generalizable as it only enrolled Han Chinese population. Patient underwent thrombectomy also outside the trial, and hence consecutive enrollment did not occur. Around 180 patients underwent thrombectomy also outside the trial protocol. Imaging modality to be chosen with respect to duration of symptoms were, however, not assessed, and etiology of underlying occlusions was predominantly atherothrombotic. Benefit of thrombectomy in cardioembolic stroke or any embolic other strokes were not determined. There were more men included than women in this study. Hence, the benefit of thrombectomy for treatment in basilar artery occlusion in women is less certain. There were limited proportion of patients who received IVT. The low proportion of patients with thrombolytic use may have been related to the requirement that in this study, particularly, the patient had to pay for their IVT. Only the thrombectomy part was being taken care by the trial. And also, there was delay in arrival to the hospital. So, what this study concludes, it supports that the patient with stroke due to basilar artery occlusion who presented 6 to 24 hours after symptom onset had a higher incidence of good functional status at 98 days with thrombectomy plus medical care than medical care alone, and thrombectomy was associated with procedural complication and with a higher incidence of cerebral hemorrhage. So coming to the critical appraisal, did this study answer focus question? Yes. Is the intervention available, affordable, and feasible? Yes. Was the trial randomized? Yes. Were all patients properly accounted for at conclusion? Yes. Was trial blinded? It's open label, but outcome was blinded. Were the patients treated equally post-intervention? Yes. Were the groups similar at the start of trial? There were minor differences which were present. And how large was the treatment effect? The adjusted rate ratio was 1.8 with a confidence interval of 1.26 to 2.6 and the p-value being significant. Then are the findings relevant to the scenario? Yes. Were all clinically important factors were considered? Outcomes were considered? Yes. are benefit worth the results? Yes. Then coming to the internal validity of the study, internal validity is defined as the extent to which the observed results represent the truth in the population we are studying, and thus are not due to methodological errors. That is, within the whatever we are seeing the population, whatever data we are getting are proper. So as per the AAN classification, it falls in category 2. And the external validity, which refers to the extent to which the results of a study are generalizable to patients in a daily practice, especially for the population that the sample is thought to represent. So as per the external validity, the it falls into moderate, because we cannot generalize. It was only conducted in the Han Chinese population. So we have also done this we have evaluated this study to the consort guidelines, and this study has well sculpted to the consort guidelines except for 2 or 3 points. So there are few other ongoing trials as well. There is Astral trial, which is being conducted in which is going to be conducted in France for patients in with basilar artery occlusion. Also, there is intravenous tenecteplase and mechanical thrombectomy on techniques on 4.5 to 24 hours after basilar artery occlusion being conducted in China. Then there is INSIST IT trial. Then there is outcome and safety of recanalization treatment in ischemic strokes due to acute basilar artery occlusion trial going to be conducted in Vietnam. So what can we extrapolate from this study? We need more RCT with constant protocol, especially for relevant outcome. Then we have to have studies which are providing data for multiple ethnicity and also multiple etiology of stroke. The optimum NIHs, we are still not clear, and the time window. Then what is the optimum imaging modality with respect to duration of symptoms? That is also not answered. Use of IVT with EVT in such cases also remains unanswerable from this study. So for this, we need more studies. Thank you.
Thank you, Manisha. I think Dr. Manisha has covered extensively this journal, and she went into depth of various other trials and looked into the assessment of the articles also. And she tried to see how we can critically appraise the article with respect to internal and external validity, and also tried to see how we can improve upon this study and use in our practice. Sir, then I will hand over the stage to you for further discussion. Thank you.
Yeah, it's a very one of the most elaborate discussions we have had in the Journal Club. So I congratulate Dr. Manisha as well as Dr. Girish and your team for making this very good presentation, very exhaustive presentations.
Thank you, sir. Thank you.
All the aspects. I would have like to get some more opinion from Dr. Prasad. He has to leave. His plane must have taken off.
We'll open it for the audience, so somebody may want to ask some questions.
That is
Asmita, please open for others to ask questions.
Yes.
Yes, sir.
Request the audience to please come up with your queries. You can raise your hands, or you can type in the questions in the question answer. Or if you raise your hand, Manish, Asmita will connect you to the.
Yes, sir, I can connect.
I think your description, I mean, the entire analysis was so thorough that it has left very few stones unturned. So it looks like most of the participants are quite happy with the way you went through the entire journal very exhaustively, entire paper very exhaustively.
And Asmita, you unmute everybody so that whoever wants to ask, they can ask.
Okay, sir.
All the participants, if you have any doubts, please come out with your questions and comments. Dr. Manisha has done really an excellent job. It's a very good paper, important paper.
Thank you, sir.
And the only problem is it's only Chinese paper. So we have to have more studies.
So
That's it.
what I thought was, compared to their country, we also have a huge population, and we have our instruct too, sir. And this is a eye opener for us that if we can organize properly and we can plan all the studies, and it is happening now, sir. And probably this whole
You
group.
can put it up to Jairaj Pandian, and
Yes,
we can
sir, yes,
instruct to you can put up. And that's no doubt. We should do this study, definitely.
Yes, sir.
We
Yes.
are already practicing this, but only thing is that formalize it.
Correct, sir.
I just wanted to ask one question. In your null hypothesis, Manisha, you put it is superior. So is it right from beginning designed as a superiority trial?
No, sir. In the alternate, I put it as superior, sir. In the null, I had put it is similar, sir.
Yeah, so that's how you do. But the superiority. But what, Girish, what is your impression? Is it in terms of superiority, non-inferiority? What category does it fall into? I think they are not mentioned it in the text. At least
Yes,
I don't know, in
sir,
supplementary files they must have probably kept, but not
Yes,
in
sir.
the main text.
Sir, what we did is she looked into the whole of the protocol, and in a small, we had a discussion regarding the same, sir. And she
Yeah.
picked up this from a small symbols where they have defined. That's what. Manisha, you can elaborate on that. We had a same discussion, sir.
Yes, this null hypothesis and this alternate hypothesis, basically, and in the protocol itself, they have per se mentioned through symbols that the H naught, the hypothesis, which is the null hypothesis, in the treatment group is equal to the per se control group versus the alternate hypothesis. So for the alternate hypothesis, per se, they have used the word superior in the protocol, sir. That's the only reason that's
Right. So, yeah, I think gives a lot of inputs as to how to plan and design studies in other populations, and also whether to include other stroke subtypes. I mean, there was at some point of time, there was an impression that I mean, there are actually some groups in some older literature, cardioembolic strokes, probably a little more common in the posterior circulation, the older books, etc. So, so to in countries like India, where we have a lot of rheumatic heart diseases and cardioembolic strokes, including the younger people, I think it might be a good idea if you can include those types of strokes also in our study. But if you include more and more subtypes, the sample size will also probably increase. And then you said the male, female, there was an issue here, isn't it?
Yes, yes, sir. Yes.
More of patients. So there are some such interesting aspects. Of course, the ethnicity itself is also a big problem.
Also, sir, this imaging modality, normally in our day-to-day practice, when
yes, yeah, that's another issue. Again, I thought they have written that they wanted a CP of minimum 2 in the initial planning to enroll into the trial. But if you look at the comparison, they have put the median for both group as 1 and 1. So if the minimum is 2, how can the median be 1 for either group?
No,
so
sir.
there also they have compromised and changed the inclusion criteria subsequently. If you look at the inclusion criteria initially, they needed a minimum of 2 CP points. That is the mid-brain Pons, the number. Score.
Actually, it is less than 2, sir.
Yes, sir.
They wanted less than 2.
Yes,
yes. The Pondex index.
So if it becomes more, then more damage is there. Probably they want to this thing. We were only worried, sir, if brainstem, we went through the literature regarding the aspect by CT and MRI. The aspect is only 40% sensitive, sir. So what my thought process was, supposing MRI is used, like we are using for diffuse
Yes.
and dawn, we'll be able to get much better patient, though less in number, and
Yes.
better outcome. That may come out probably in the next, whatever the trial she has shown.
Yeah. CT, including the source images, it's not a very good imaging modality for posterior circulation stroke. Unless it is
intracranial,
cerebellum and occipital lobe and
intracranial MRI is also good as compared to extracranial. I think it's a good idea to have MR and MRA. Now, one more question I wanted to ask is NIHS a suitable scale for posterior circulation strokes? That is the severity.
Yes, sir. Many things we cannot assess with NIHS.
Hmm.
That
So-
difficulty we face in day-to-day of our practice also, sir. So
We have to
the
devise
point is
another-
we do not know. So we can't say that it is bad also. So probably unless people start including posterior circulation in the clinical trials, and then we
if
prospectively.
you look at the parameters that are given, they are very less of posterior circulation, cranial nerves,
Then yeah.
and eyes, and these things are not there that much, which we should do.
Like PC
Okay.
aspects, we need a
Hmm.
PC and a score also.
Yeah. Yes.
I think probably somebody must have already done that. Did you do a literature survey whether any other modified NH stroke scales are already people have looked at and tried to develop?
no, sir, I have not done a literature search for that, sir.
I think you can now have a fresh look at it.
Yes,
There is
sir.
a modified NHS stroke scale. There's a modified one.
Yes,
It's available.
You can do
Okay.
so. Yes, sir.
I think.
I think yeah, we are reaching 8:30.
So I think we should call it a day
Yeah.
because there are no
So-
questions. I think very lucid presentation, and I think we compliment the team from NIMHANS. They have done a wonderful job, and we're all going to have a mid-term congress in on July 28th and 29th in Pune, Bharati Vidyapeeth. And, most of the speakers have agreed to participate, and we're going to have a feast of the scientific program, which is being finalized, and I'll put it up to you, Dr. Sunil, in due course of time next week. Okay. And with this, I think we'll say.
Yeah. I'll just say that next month also, probably before the midterm conference, we should be having one more of the journal club.
April, no, there is April, May, there are two. April,
Yes,
May,
yes.
June,
So I think from the team from Ludhiana is likely to be presenting.
we'll ask.
Next week. Yes, Dr. Pandian, I already talked to him and he has agreed.
Okay, we'll ask Pandian too.
Remind him only. Yeah. Yes.
Okay.
So
Right.
please
then.
do join
Hmm.
in the next meeting also and please and participate actively. Thank you very
Right,
much. Once again.
Okay. Good night. Good night, everybody.
Night to all of you.
Thank you, sir.
Bye. Have a nice
Thank
week.
you, sir.
Thank you, sir.
Thank you, sir.